Hi, Doug. Would you like to do a mic check?
Yes, can you hear me?
Loud and clear, thank you.
Wonderful, thank you.
Kenneth, would you like to do a mic check?
Sure, I'm right here, and if my time comes, I'll just share the document directly to focus the group.
Do you want to try to share your screen?
Oh, sure.
Just to do a little test there.
So,
Yes, we can see that. Thank you very much. You're all set. Just a courtesy announcement that we are now live on the internet. Good afternoon, Daniel. Would you like to do a mic check?
Hi, good afternoon. Can you hear me okay?
Yes, loud and clear. Thank you.
Great, thank you so much.
Hi, Paul. Would you like to do a mic check?
Sure. This is Paul Lorenz.
Loud and clear, thank you.
Thank you, Jill.
Hi, Frank.
Hey Jill, how's my mic working?
Really good, thank you.
All right, cool, thank you.
Mikkel, would you like to do a mic check?
Hi, this is Mikkel. Can you hear me?
Yes, we can. Thank you very much.
Thank you.
Good afternoon, Vice Chairperson Ellenberg.
Hey Jill, how are you?
Good, thank you. You're all set. Have a good meeting.
All right, thank you so much. Thanks in advance for your help.
Just a courtesy announcement that we are live on the internet. Good afternoon, Jean. Would you like to do a mic check?
Yes, hi Jill, this is Jan.
You're all set. Thank you.
Thank you.
Catherine, would you like to do one?
Hi there.
We can hear you as well. Thank you.
Thank you.
Dr. Fong, would you like to do a mic check? Good afternoon, Jill. Would you like to do a mic check?
Yes, can you hear me?
Yes, we sure can. Thank you.
Thank you.
Dr. Nguyen, did you want to try one more time?
Hi, Jill. Yes, I can hear you. Thank you.
Okay, thank you. Hi, Minesh. Would you like to do a mic check?
Sure, this is Vinesh.
Perfect. Thank you.
Thank you.
Yvonne, would you like to do a mic check?
Yes, I would. Good afternoon.
You're all set. Thank you.
Thank you.
Margaret? Margaret, would you like to do one?
Hi, Margaret Obelaw here. Thank you.
You're all set. Thank you. Good afternoon, Jackie.
Good afternoon.
Loud and clear. Thank you. Chairperson Simidian, would you like to do a mic check?
Hi, this is County Supervisor Joe Simidian. How's the mic working?
Perfect. Thank you.
Thanks for your help.
Dr. Sarah Cody, would you like to do a mic check?
Yep, how's it sound?
Perfect as well. Thank you.
Thank you.
Just a courtesy announcement that we are live on the internet.
Thank you, Ms. Doyle. Have we been joined by my colleague Supervisor Ellenberg?
Yes, sir. She is in the room.
Here.
There she is.
Good
All right.
afternoon.
Thank you so much. Then, that being the case, we can go ahead and call this meeting of our County of Santa Clara Health and Hospital Committee to order. This is our regularly scheduled 2 p.m. meeting, and we'll begin by asking the clerk to call the roll and establish the presence of a quorum. Ms. Doyle?
Good afternoon. Vice Chairperson Ellenberg.
Here.
And Chairperson Simidian.
Here.
Thank
All right.
you. You have a quorum.
Thank you very much. That takes us to item number 2, which is public comment. Public comment, of course, is that portion of our agenda set aside for comment by members of the public on non-agendized items that are properly within the jurisdiction of our committee. Let me ask the clerk, do we have anyone lined up to speak under public comment?
So far, sir, we have 2 hands raised.
All right, let's go ahead and take them in order. And again, 3 minutes is the custom and practice of the committee when there are that many speakers. Go right ahead.
Thank you. Our first speaker is Scott Largent. I am unmuting you. Please accept the unmute. You will have 3 minutes to speak, and the timer will start when you begin speaking.
Thank you. Good afternoon, everyone. Scott Largent. There is, you guys know I go to all the different court appearances and what I can get into and what I can observe, and it's like a cat and mouse game. You're constantly trying to figure out different ways to figure things out. Some of the stuff is a waste of time. Some of the stuff is not. My biggest concern was my first line of defense in Santa Clara County. When I had met Victorious Alexander, was in that office, and he basically started kind of lighting a fire underneath me. He said, Scott, they should be helping you. You should have a dignified meeting. They should, but they won't. Now, different legal terms and names of different motions that I've started to learn, I'm wondering why the Public Defender's Office is not utilizing those legal tools to better help indigent clients, such as filing, writs of habeas corpus. I thought that would have been appropriate for a lot of people that I know that were incarcerated, that were activists, or the system is just retaliating against them. They play dumb at the Public Defender's Office, that they really don't know what a lot of this stuff is, and I don't buy it. You guys know that, and Susan, you're an attorney, so you really know. Now, the other weird ones are a motion that my attorney filed, which is a Murguia motion. Now, I didn't really know much about that. The Public Defender's Office continues to play stupid about that one, and they just keep not filing these motions for people. And many of these people that I've met are really being harassed by the system. They're being abused in the civil channel. And as long as I can properly explain this better, and I've been working on, I set up Zoom studios now for different businesses, and I've been getting really good with the slides and, the interactive end of things, so I can better explain things. So it's not some 20 or 30-minute video. And it really lets the public know, look, this is what happens in this courthouse. This is how people's rights are being violated. This is how the public defender doesn't get involved. Why don't you guys ever do anything about it? I'm bringing legitimate concerns to your table. I mean, this is right out in front of you, and it's time to start getting involved. When somebody is poor, homeless, or mentally ill, why can they not have a jury trial in Santa Clara County? This is what happens when you decide, hey, I want a trial. They say you're nuts, okay? Then they send you through the Manly hustle, and they convince people that they have to be in Manly's courtroom when it's really voluntary. And it's you're tricking these people because they can get right back into the Hall of Justice, which I'm telling them to do. Okay, I'm not an attorney. They can come after me for all they want for me providing ghetto legal advice from my van. But what else do I have to do to protect these people's rights and get them up off the streets where you guys basically let them get stuffed? I don't get it.
Thank you. And turning again to the clerk, I believe we have one more speaker.
Yes, sir, one more.
And welcome.
Our next speaker is Chloe Ship. I am unmuting you. Please accept the unmute. You'll have 3 minutes to speak. The timer will start when you begin speaking. Chloe, unfortunately, you're running an older version of Zoom, so you're unable to speak. That concludes our speakers, Mr. Chair.
All right. Thank you, Madam Clerk, and regrets that we had some technical difficulties for our second speaker. All right. That concludes public comment, and that takes us to item number 3, which is to approve the consent calendar and any changes to our committee agenda. As indicated in the published agenda, the consent calendar today includes items 10 through 17. Supervisor Ellenberg, a motion and any changes that you'd like to suggest?
Yes, a change first. I want to thank Paul and the VMC staff for the really helpful report on item 5. My staff received some helpful additional information prior to the meeting on other indicators that are being monitored by VMC for maternal and child health. And just given the other demands at the hospital right now and the discussion today, I'd like to add item 7 to the consent calendar, and of course, thank staff for their continued efforts to improve maternal and child health services at VMC. And if moving that item to consent works for you, Supervisor, I'm happy to make a motion to approve the consent calendar as amended.
Thank you, Supervisor Ellenberg. So the motion is to move the agenda, the consent calendar with one change to our agenda, and that is to add item 7.
Item 7.
And I'm happy to second that. And before we see if there are any speakers on the consent calendar, I think you made reference earlier to item 5, and I may have simply misheard you.
I misspoke. I meant item 7, so thank you for hearing what I meant to say.
We're all squared away. Thank you. The motion then is to approve the consent calendar with the addition of item 7, and I'm happy to second. Let me check with the clerk to see if we have speakers on that item.
We do not.
All right, then without objection and hearing none, we will move to a roll call vote just for the record. Madam Clerk?
Vice Chairperson Ellenberg.
Here. Yes, sorry.
And Chairperson Simitian.
I am also an aye vote. The consent calendar as amended is approved. That takes us to item number 4, which is to consider recommendations relating to our medical staff and the allied health professionals. Possible actions are items A, B, and C as contained in our published agenda. And let me ask who will be presenting on this item today.
Good afternoon, it's Yvonne Karanis. I am the enterprise president of the medical staff, and I am here to present the credentials report. In addition, I am presenting the enterprise privileges on orthopedic surgery, as well as addition to the O'Connor surgery privilege list for bariatric surgery. In addition, I wanted to let the board know that we have granted temporary extension of privileges to our outpatient primary care doctors to provide inpatient services, and for our inpatient hospitalists to be able to provide ICU services. We are in the process of figuring out how this is going to look, but I would anticipate, based on our climbing numbers of COVID patients, that these physicians will be needed in these new roles shortly. In addition, we have temporarily suspended our secondary site onboarding process, our administrative process, to allow for physicians to move between sites and to allow for allied health staff to move between the hospital sites. This will allow us more flexibility in staffing for patient care across the enterprise. And lastly, I wanted to let the board know that the revised bylaws are on the full board agenda for December 15th. I really want to give a shout out to all of the folks on the bylaws committee, all of the physicians and others who worked on this document. I'm extremely proud of this document, and I think that it represents the integration of our 3 hospital sites and was a collaborative effort across the enterprise with representation from all 3 sites. So I just wanted to let you know that that's coming on the 15th.
Thank you, Dr. Kranis. Let me turn to my colleague, Supervisor Ellenberg, who will need to unmute herself, see if she has any questions or if she's prepared to offer a motion to approve the recommended actions contained in our published agenda.
Move approval, and thanks, Dr. Kranis, for your report today.
Thank you.
Motion by Ellenberg, second by Simidian. Let me check with the clerk to see if there are any speakers in the queue.
There are none, sir.
Thank you. Then, Madam Clerk, if we could ask you to please call the roll.
Vice Chairperson Ellenberg.
Yes.
Chairperson Simidian.
Yes. Thank you very much. The item is approved unanimously. Thank you again, Doctor.
Thank you.
That takes us to item number 5, which is to receive the report from the Facilities and Fleet Department with respect to our Santa Clara Valley Medical Center and the Office of the County Executive report on the Child and Adolescent Psychiatric Facility at the VMC campus, scheduled to open fall 2023. And let me turn to Dr. Smith and ask him who he would like to present on this item.
We're going to start with Doug Koenig.
Thank you. Mr. Koenig, welcome.
Thank you. Good afternoon, Supervisor Smitty and Supervisor Ellenberg. Not too many updates to the report you have before you. The first, just to emphasize, the design team is proceeding with the construction documents as scheduled. Our CMR contractor is getting ready to release requests for proposals for our delegated design partners, which would include curtain wall design manufacturers, as well as elevators. They will also be going out with requests for proposals for the design assist partners, which would include our mechanical, electrical, and plumbing contractors, to get those folks on board to participate during the pre-construction period. Lastly, staff did meet again with the Department of Public Health to try and resolve the meta-psych bed issues. Staff did provide a list of subacute procedures that we would like to be allowed to perform in a psychiatric hospital. And we are awaiting their determination as to whether or not that would kick in the requirements for a skilled nursing facility, or whether or not we can continue solely as a OSHPD 5 acute psychiatric hospital. Are there any questions?
Let me turn first to Supervisor Ellenberg, and then it will not surprise you, Mr. Koenig, that I have some questions.
I have no questions.
Thank you, Supervisor. Let me begin by asking how things are going with OSHPD. My recollection is that that was a process with some uncertainty built in that had been the source of concern by staff. So how are we doing with OSHPD? Let's start there.
I think regarding OSHPD, the main uncertainty there was that they were waiting on the Public Health Department's determination. And they said that they would go along with whether OSHPD 5 or OSHPD 2 if public health required a skilled nursing facility. Other than that, they're cooperating We will be submitting an application to try and get collaborative design review, which promises to get us to plan approval earlier than the schedule currently calls for.
Thank you for that. And just to be clear, Mr. Koenig, when you say waiting on public health, you're talking about state public health?
Yes, California Department of Public Health. They're the ones that will make the determination as to whether or not what we're proposing to do would rises to the level of a skilled nursing facility.
Thank you for that. I just wanted to make sure folks weren't thinking we were talking about our own local public health department for those who aren't involved in this the way you are. I do want to ask before I go through the six-person request or question. I note on the staff report we continue to see design completion February 20 of 21. What is that likely to give us at that point? What should we be looking at when we get to a point that's called design completion?
Well, that would be the construction documents. That would be when they submit those documents to OSHPD to begin OSHPD's review.
All right. And are there also what I'm going to call some pretty pictures that we can look at that give us a rough idea what this thing looks like inside and out? I know I've been in touch with the architectural firm. Seems to me like much of that is already well advanced, but for our board members who are perhaps not quite as needing of construction documents, but who are perhaps interested in understanding sort of what this thing is and will be and looks like. What do we have that fits that description? I'm going to call it for a layperson and a policymaker.
I think I mean, the design team could put together any presentation that at any time pretty much that anyone would like to see. They've got their renderings very well developed, both interior and exterior.
Also, say that Doug and his team did a terrific presentation in my district for neighbors that live in close proximity to VMC, and it was very understandable and very engaging.
Thank you. And as I say, I did have a chance to spend probably an hour and a half with folks in a Zoom meeting who seemed to have renderings that were quite helpful in displaying and communicating what we had in mind. So my hope and expectation is that by February, there'll be even more ability to provide that kind of information. And Mr. Koenig, I think what I'm going to do right now is indicate that we should plan on a sort of a formal presentation sometime in February when the design completion is a reality. And again, not looking for a presentation of the working documents as much as an ability for all parties at the committee and the board level to understand precisely what it is we're engaged in undertaking. And I'll hold off in terms of exercising a judgment about whether that's something we ought to do here in the committee or whether we want to take some brief period of time at a full board meeting just to keep everybody in the loop. But I do want to give you and the team a heads up that when we get to February, this will be a milestone that not only is a box we can check, but one where I'm going to anticipate we'll have some public communication about where are we headed. Okay, and Dr. Smith, do I see you leaning in or at least just adjusting your face mask? I'm not sure, sir, whether you want to be called on or not.
No, I was just saying we'd be happy to do whatever presentation you want.
All right. Then the last piece of the conversation, as I know you've come to expect, is I am looking at the staff report. It indicates design completion February 2021, construction beginning February 2022, open to patients November of 2023. And my question for all the members of the team, and let me just start with Mr. Koenig, is are we still on track to meet that timeline, Mr. Koenig?
Yes, we are.
And Mr. Ohashi?
Yes, sir, we are on track.
Mr. Sodi?
Yes, we are on track.
Thank you. I think Jeff Draper is with us today. Mr. Draper, are we still on track?
We are on track, sir.
Thank you. And how about Mr. Lorenz?
Yes, Supervisor, we are on track.
Thank you. And Dr. Smith, are we still on track to meet the February 2021 design completion, construction beginning on February 2022, and open to patients on November of 2023?
Yes, we are.
All right. Thank you very much. Then if Supervisor Ellenberg has no comments or questions, we would be pleased to receive a motion at this time to simply thank you. We have a motion from Ms. Ellenberg, which is the recommended action, which is simply to receive the report. I am happy to second. Thank you, by the way, to all who are keeping this on track. I want to make sure I communicate that, as well as my continued interest and concern about it. And let me just check with the clerk to see if we have any members of the public who would like to speak to this item.
There are no speakers, sir.
Thank you. Then if you could call the roll on item number 5, please.
Vice Chairperson Ellenberg.
Yes.
Chairperson Simidian.
Yes. And the motion carries unanimously. Thank you again, one and all. That takes us to item number 6. And item number 6 is the report from our public health officer, focusing, of course, on the COVID pandemic. And let me welcome Dr. Cody and let her or you, Dr. Smith, sort of direct the presentation at this point. I know Supervisor Ellenberg and I will both have questions and comments, but let's begin with you.
Yeah, I think that Dr. Cody will start off, and we'll have Dr. Fensterscheib, and we'll talk about the update and also vaccine. And I'm doing the audio visual, so I'll ask Dr. Cody to let me know when she wants me to start sharing.
Thank you, Dr. Smith, and thank you, supervisors. This is Dr. Sarah Cody, and I'm joined by Dr. Marty Fensterscheib. Today, we want to provide you with a more in-depth update than we were able to provide yesterday regarding COVID-19 vaccine planning. And Dr. Smith, in his many, many, many forms of service to the county, is also going to assist with audio visuals and share the slides. Thank you. So Dr. Fensterscheib and I are going to tag team. What we want you to come away with is a little bit of context around our vaccine planning. We'll also review for you the roles of our federal and state partners, and then bring you right up to the moment what we know as of now regarding the vaccine allocation for us here in Santa Clara County. So I will start and then I will pass the presentation off to Dr. Fensterscheib, and afterwards both of us will be available to answer questions. So if I could have the first slide. I wanted to put vaccination in context before we dive in. This is a slide that I shared at a board meeting a while ago, the Swiss cheese model of defending ourselves from the virus. And as you may remember, the big take-home message is that no one intervention works by itself. They all work in concert. And when they're all layered together, we have a much better chance of the holes in the cheese not lining up and being able to defend ourselves from the virus. We've talked a lot about the personal steps that each person can take, as well as our shared responsibilities, testing, contact tracing, increasing ventilation, communication to communities that have been particularly impacted, et cetera. And of course, vaccines are an enormously important part. But they are part, not whole. So I wanted to put that frame out front and center. Next slide. The reason why is that it is going to take us quite some time to reach herd immunity. So let me walk you through this. The top here is where we are now with no vaccine. So that slice in the Swiss cheese defense is not available to us. Most of us are not immunized and not yet infected, but this is such a contagious virus, it continues to spread, hopping from a susceptible person to susceptible person and causing illness. Right now, we will share with you that we will be getting a limited, very limited number of vaccines. So we will be able to vaccinate a tiny portion of one priority group to start, which means that all of the current prevention measures that we're doing need to stay firmly in place as this vaccine rolls out. Eventually, and we don't have a time, we are not able to give a time, but eventually more and more of the population will become immunized. And at some point, and many experts take that it takes at least, if not greater than 70% of the population to be immunized for there to be herd immunity, where the spread of disease is halted. And at that time, we can begin to ease up on other prevention measures, those other slices of cheese. Next slide. So just a real brief review. I just wanted to reshare data. This is all from our dashboard, but just remembering how COVID has been impacting the population living in our county. So we, as many communities, continue to see disparities by race, ethnicity in our COVID cases. And here we have more than double the number of cases among the Latino population. And as was discussed at yesterday's board meeting, while we don't see those disparities in the Asian population as a whole, we need to look at the Asian subpopulations. And those are data that we will be sharing next week. Next slide shows the disparities in COVID-19 deaths. And there's two slides I'm going to share regarding the disparities in COVID-19 deaths. Here you see the disparities aren't quite as great. However, there are still disproportionate number of deaths among Latinos in our county. And in the next slide, and this is really important data to understand, I think it helps you understand some of the prioritization decisions that have been made by our federal and state partners. On the left side, you can see long-term cases among residents of long-term care facilities versus people who are not residents of long-term care facilities. And only 5% of the cases are among long-term care facility residents. By contrast, deaths among long-term care facilities represent 44% of all deaths. So 5% of cases, but 44% of deaths. So a real disproportionate number of deaths are borne by long-term care facility residents and staff, although I must say it's far and away mostly residents. So the next slide, just to zoom out a little bit, what we'd like to do is give you just some context around the state and federal roles. And this is really a big, broad overview before we share some details. So the COVID-19 vaccination journey, very different than any other vaccine, and that the clinical trials and the manufacturing were really happening in parallel, which normally the trials, vaccine trials would go on, and then after that there would be manufacturing and distributions. But this has been done in parallel for the COVID-19 vaccines. The FDA is the only body that can review, approve, and license a vaccine. And so with these vaccines, we're waiting for initial EUA or emergency use authorization to use the COVID-19 vaccines. So anyway, the vaccines, at the same time that that's going on, the manufacturers have also been ready to ship vaccines and indeed have pre-positioned some vaccines at key distribution facilities so that they can reach the sites of administration as quickly as possible. Next slide. So again, the federal role with vaccines, two main agencies these are the main ones, but it's not limited to. So the FDA has a committee, VRBAC, the Vaccines and Related Biologics Products Advisory Committee, and they discuss the EUA requests and then advise the FDA about whether to grant an EUA. The CDC has a committee, ACIP, or the Advisory Committee on Immunization Practices, that looks at the epidemiology, who's been disproportionately infected or impacted or most at risk of spreading an infection. And they issue recommendations around priority groups, as well as guidance on vaccine administration once a vaccine receives EUA. So we'll talk about this, but for example, with these vaccines, they've issued recommendations for the initial priority groups, but have not yet issued guidance for the vaccines themselves, because there's different guidance for different vaccines. Next slide. So the work of the ACIP so far, they have prioritized healthcare personnel and residents of long-term care facilities as phase 1A. So that's the highest priority group to receive the first little bit of vaccine that's distributed. That's the ACIP. Now, because that group, healthcare personnel, is a very large and very broad group, the state, the California Department of Public Health, has further refined that group, healthcare personnel, in order to be able for locals in the state to be able to prioritize and really understand where does it go first, because we can't do all healthcare personnel at one time. And so in the next slide, you'll see this is the California Department of Public Health sub-prioritization tiers for phase 1A, the healthcare personnel. And so it's been divided into 3 tiers: tier 1, tier 2, and tier 3. And I'll turn it over to Marty in a moment. But the take home here is that the first bit of vaccine that will be coming to our county will not even be enough to get us through the first 2 bullets in tier 1. Because that's a very, very large group of individuals that fall into tier 1, bullet 2. And in the next slide, this is just to give a sense of, I think my take-home message is that the allocation process is rather complex, and this is to give a feeling for the complexity and what it looks like on the ground in a county. So for example, the federal government allocates vaccines to states, and then the states allocate vaccines to local health departments. And we'll walk through what we know about that to date. However, the federal government also makes direct allocation to federal agencies like VA hospitals, Indian Health Service clinics, federal prisons, etc. And the state health department also makes direct allocations to state-run entities and multi-county entities. And so on a local level, we may see those entities that are located in our county that are receiving direct allocations from the federal government or from the state government, as well as receiving direct allocations from the cash that comes into the county. Next slide. So I'm now going to hand the presentation over to Dr. Fensterscheib, who will talk about the details in our county and what that looks like and what we know to date. Dr. Fensterscheib.
Thank you, Dr. Cody. So in this slide, we're looking at the first 2 front-runner vaccines that we're likely to see and are likely to get the first approval. The Pfizer vaccine is first up, and let's see, today is the 9th, so tomorrow, December 10th, it will go in front of the FDA with all of its information that it has from its trials and all of the data, and we anticipate approval by the FDA, but it's not a done deal until the FDA does formally approve the vaccine. Pfizer is the vaccine, of course, that is a bit challenging for all of us in that handling the ultra cold storage requirements is challenging. And it requires some ultra cold storage freezers that are not readily available to everyone. So that gives some limitation to that particular vaccine as far as being a vaccine that can be administered by all usual providers, I should say. There's also a minimum order of 975 doses, and so they can't break up we call it the pizza box, because they told us it's a tray and about the size of a large pizza, and it contains that many doses, and they can't break up one of those. So again, if you're a facility that has less than that, then again, you will not be receiving that Pfizer vaccine. The date of anticipated arrival, again, so we hope that it will be approved tomorrow on December 10th, and then we expect that next week the vaccines will begin being shipped from the manufacturer of the Pfizer vaccines directly to the providers that have been approved for dispersal of the vaccine, administration of the vaccine. The second vaccine is Moderna, and that vaccine is right on the heels of Pfizer. They are expected to go before the FDA the week after on December 17th. And this vaccine is a little bit easier to store and handle. It requires a lesser type of freezer. In fact, we were looking at -20 centigrade, sounds really cold, but it's actually only -4 Fahrenheit. So for all the scientists out there, it's not so difficult to find the freezer with a -4. The other good thing is that the minimum order for this particular vaccine is only 100 doses. It comes in vials of 10 doses and boxes then of 10 vials. So 10 vials times 10 is 100 doses, much more manageable. And then, of course, on both of these vaccines, they require 2 doses, 21 days for Pfizer and 28 days apart for Moderna. And the questions come up many, many times. The allocations that we are getting are to be used all for first dose vaccines and first administration, and we are not to hold back any vaccine for a second dose. We are told that we will get those in time. Next slide. So as we've mentioned before, California will be receiving 327,000 doses of Pfizer immediately after approval, and Santa Clara County has been allocated 17,550 Pfizer doses. That equals 18 of those pizza boxes. We are also required, at least in this first allocation of the Pfizer vaccine, to share a very small amount, 230 doses, with San Benito County, and we will make arrangements to ship some of that vaccine to them. We were also just informed yesterday, and this is kind of hot off the press, that the Moderna doses have been allocated to states, and that upon approval, again, California will receive 673,000 doses of Moderna, and that will translate into 39,300 doses of Moderna for Santa Clara County. Thus, our total doses of these 2 vaccines, once we get them, will be 56,850 minus the 230 to San Benito County. Local health department's role. We are not, again, in the business of doing any of the prioritization. That's all being done by the feds and the state, as we've talked about. However, we will be vaccinating some of a portion of the phase 1A populations that can't otherwise receive the vaccine that are in that phase 1A tier 1. And that mainly are the workers, the healthcare workers at these skilled nursing facilities. We also, in public health, receive all the information on what the requirement, what the ask is of all of the facilities as far as what they need and numbers of staff that are in those various tiers. And then as the county receives the doses, we then allocate them out per their request. And then, of course, that's determined by the amount of vaccine that we receive. Next slide. And so this is just, quickly go through this. This is just a summary of what the state is getting. And this is just makes the point here that we will be expecting to get vaccine on a weekly basis in the foreseeable future. And everything on there is what we've talked about, except that Pfizer second column there that says 300,000 plus doses. That's the next allocation to the state. We do not know yet what portion that will be given to us in Santa Clara County, but we will probably get that information soon. And next slide. We were required to put together a vaccine plan, which we did and was submitted on December 1st. And these are the 15 sections that were required of that plan. We have a large group of people within the health department that have been working on this, and each of the work groups completed the various areas of their specialty corresponding to these 15 areas required on the plan. Next slide. We also, in the plan, were required to have 2 external facing groups to help us in this planning process. The first one was the Vaccine Provider Task Force, and this is made up basically of the providers in the community that will be receiving vaccine and will be distributing the vaccine. And we will be and have been meeting with them, providing guidance on vaccine handling, storage, administration, and documentation, because it gets very complicated. We've talked about the storage issues and also the issues of documenting who gets what. You have to receive the same vaccine as your second dose as you got for the first dose, and so those records must be kept up to date. And also, you must be alerted as to when to return for your second dose. So the callback requirements of those systems have to be in place. The second external facing group is our Vaccine Community Stakeholders Working Group, which just met on Monday of this week, and we had over 100 people on that call. This is made up of a large swath of the community, made up of business, faith communities, labor organizations, also people that represent various communities in our county and others. So we had a very good meeting, first kickoff meeting with very good reviews. People are very, very, very happy about being brought into the fore and being part of the decisions and the discussions about how we can make sure that we will have a successful campaign in getting vaccines to all members of our community. Next slide. This is a picture of the vaccine plan that we submitted. We had a discussion yesterday and previously, especially with Supervisor Simidian, and realized that the language in part of our vaccine plan was not really expressing the intent that we had in making sure that we had points of distribution in all areas of our county, no matter where people resided. And so we wanted to clarify that, and so we rewrote that to best express our intent, and we resubmitted, I believe yesterday, the revised plan to the state with the language, especially in that particular paragraph. Next slide. As I mentioned, we in public health will be providing vaccine to approximately 6,000 skilled nursing facility staff working again in these SNFs in our community, because each one of these SNFs are small, and at least with the Pfizer vaccine, they are unable to basically handle or store those large quantities of vaccine, nor can they store it. So public health has been in negotiation and discussion with the SNFs, and we are working out methodology and the logistics for providing the vaccine to this very high-risk group of people that are taking care of very high-risk individuals. So the residents now, that was for the staff. We're talking about that the health department will vaccinate. We did mention back on that slide that the federal government would be providing vaccines to some direct receivers of this, and the decision at the federal level was to develop a program where the retail pharmacies such as CVS and Walgreens will be receiving vaccine directly from the federal government, and their task is to go and vaccinate the residents of the long-term care facilities. We have not seen details of that program, but those will probably come soon. And again, additional county healthcare workers within the community, again, depending on the need and whether there is, whether they do or don't have another provider to provide the vaccine to them. Next. And I think we're done. So I'll stop there and turn this back to Dr. Cody.
So we're happy to take questions.
Thank you very much. Supervisor Ellenberg, I'm going to weigh in with some questions and then turn to you in a few minutes. Thank you for your patience. Dr. Cody, early on in your presentation, you had a couple of bar graphs that indicated the disparate impacts between and among various groups. Forgive me, I don't think the pages were numbered, but do you recall the slides that I'm referencing?
Yes.
If you could go back, because part of what I wanted to just take a moment to more fully understand is the significant disparities by race and ethnicity in COVID-19 cases, and I'm looking at the column labeled white, where there was a very clear disparity between the number of cases versus the number of folks in the population. But as you then pointed out, the disparities were not so significant in the death counts. Can I ask you to go back to those slides and go first to the race ethnicity regarding cases, and then to the next slide regarding the total number of deaths, please?
Sure. As Dr. Smith brings those slides back up, I will say, again, these are data from our dashboard and from our website, just to remind us all of some basic patterns that we see of COVID. I don't have the details to share with you, but you have correctly noted that while whites are underrepresented in terms of cases and their share of the population, it's about almost equal with deaths. That may have to do with the other slide regarding long-term care facilities and the race ethnicity composition of residents of long-term care facilities. In other words, if whites are overrepresented in long-term care facilities and long-term care facility residents are overrepresented among deaths, that may be the explanation.
Thank you. And if you have additional information on that disparity over time, I would appreciate receiving it. In fact, we'd ask that you share it with both members of the committee and or the rest of the board if possible, because I do think it was striking, as you pointed out, that as I look at the numbers, the number of cases in that demographic is just 40% of the total in the population, but the number of deaths is actually slightly in excess, as you pointed out, of the proportion of the county population that you've identified as white. And that's just an intriguing notion. It's a pretty dramatic difference. So I just ask that if we can get more clarification on that we do. I do want to also ask on the Pfizer being rolled out first and Moderna then following close on its heels. Do we anticipate that at some point there will be any analysis of the efficacy of the two vaccines? And if so, who's going to do it? When would it happen? And does that create a set of issues then about one being, quote, better than the other in somebody's assessment and demand for that one being higher priority than the other? What's your thinking about how that's likely to play out, please?
So it is the job of the FDA to look at vaccine efficacy, and that is part of the EUA review. And it is the job of ACIP to not only provide the priority groups, but provide the guidance. So for example, if in reviewing the vaccine data, it turns out that one vaccine is better suited to one population and another vaccine is better suited to another population, that would come out in the ACIP guidance that accompanies once a vaccine is approved. And that's not uncommon. For example, there's a number of different vaccines for pneumococcal disease, and some are recommended for some groups and some are more recommended for other groups. And that's an ACIP role.
And do we have any sense of when, or if that's already happened, but otherwise when that kind of more finely grained analysis and recommendation might be forthcoming?
Well, in general, once a vaccine receives an EUA and is rolled out, I believe that the ACIP guidance for use of that vaccine comes shortly thereafter, because it's needed by providers who will be administering the vaccine.
Well, so let me just say we have one we think is coming in a week and another the week after. So, let's say it's mid-January and we have two different vaccines to provide. Will there be a conversation or challenge around the fact that one vaccine might or might not be better suited to one particular population?
I don't know. I don't want to speculate. What I can tell you though is that there are a number of different kinds of COVID vaccines. These two vaccines, the Moderna and the Pfizer, are the same kind of vaccine. So there's a good guess in that they would behave in a rather similar fashion. They're very similar vaccines.
All right. Thank you. As I mentioned yesterday, literally in real time during our board meeting, I suddenly encountered a story in the New York Times that indicated that the federal government was looking to collect relatively personal information about those who had received the vaccine and to require that as a condition of distribution. And I asked at the time if you could sort of take a look at that issue in anticipation of today's meeting. I don't know how much time you have or haven't, but anything you can share with us about that debate?
I unfortunately don't have anything I can share. We've been working long hours on many things, and I did not even have time to read the New York Times article. I don't know whether Dr. Smith has any insight he might offer.
Yeah, I have a little bit, not a whole lot more, but there is apparently an agreement between the feds and the states having to do with information transfer. We have our legal staff trying to get a hold of that to figure out which information is being demanded by the feds. Obviously, some information might well be understandably needed, like, address and, name, so that they can follow up on any side effects or make sure that there's appropriate distribution. Other information obviously would be inappropriate, things like, national status or, any medical conditions or whatever. We're very concerned about the fact that any information transfer might discourage people from participating in the vaccine program. And so once we get a handle on the agreement between the state and the feds, we will be approaching the state government about whether or not we agree or whether or not this complies with our surveillance ordinance. So county council is on it.
That's correct.
Doug's on it.
Yeah. Well, we have a small. Candidly, we have a small team of people who are actively engaged in looking at this moment.
Sorry,
you, Mr.
Doug.
President.
I didn't realize you were on the phone.
Let me just ask everyone who's on the call. Are we anticipating that at our final board meeting of the year, which is next Tuesday, the 15th, that we will have a COVID update at that time? That has been our practice at virtually every meeting in recent months.
Yes, we'll have a COVID update on the Tuesday meeting.
Then
we
Dr.
have
Smith, excuse the interruption. That's all right. We're it's difficult with this format. Dr. Smith, Mr. Press, Dr. Cody, could we just ask then that we get an update on this issue of data sharing at that time on the 15th? That ought to give you time to feel a little more fully informed and to explore some of the possibilities.
Yes.
All right. And I know this won't come as a surprise to anybody on the call, but I know there are sometimes trade-offs, but given some of the misuse and abuse that we have seen of data, which under other circumstances we might consider appropriately collected, I think there's going to be a hypersensitivity to this. And the concern that Dr. Smith raises about the potential for such an effort to dissuade undocumented residents in our county from participating in the program is, I think, a significant one with implications not only for that part of the community, but for the entire community in as much as we move between and among various cities and towns and different venues and all mingle with one another. So it's got some public health implications, it would seem to me, not just for members of the undocumented community, but for the entire larger community. Let me move to a different, we'll look forward to it then at the meeting on the 15th. Totally different issue. And this is again one where if there is information, I would be pleased to have it shared, but if not, I'll simply ask that somebody come back to us with a report at our COVID update on Tuesday. Dr. Cody or others, are you all familiar with a existing medicine called fluvoxamine, if I am pronouncing it correctly?
Fluvoxamine? Not off the top of my head.
All right. Well, thank you. Not an attempt to put you on the spot or a trick question. It came to me lately as a development. I have no knowledge or opinion whatsoever. But if you could take a look at it, FLUVOXAMINE, and see whether it has some relevance to the way in which we approach the pandemic here in the county, I would appreciate that report back either off agenda or at the meeting on the 15th. How's that for a request? Okay.
We'll see what we can do. Thank you.
Thank you. And
I have a little bit of information on that if you'd like.
Sure, Dr. Smith, whatever you'd like to share, I'd appreciate it. And again, I'm not asking folks to speculate on things they don't know, but if you can share some information, I'd appreciate it.
This is a antidepressant, also called Luvox, which is a selective serotonin uptake inhibitor. And there is some suggestion in some of the literature that certain antigen receptors that are related to this classification, serotonin uptake, might, very big might, make it easier for the virus to be transmitted once it's in the body or cause an infection once it's in the body. There's lots of speculation that this type of medicine might help. It's purely speculation at this point. We'll get more information for you on Tuesday.
Thank you. Appreciate it. And now I want to go to the issue that I raised yesterday and offline on Monday as well about how we ensure countywide coverage of vaccine distribution. As I believe it was Dr. Fenster-Scheib indicated earlier in the conversation, I had previously raised concern about the fact that the vaccine planning that we were privy to indicated that the vaccine, when available, would be distributed, and I'm just going to go back, forgive me, pursuant to Section 6F of the roughly 60-page plan through our county fairgrounds and the Nine Valley Health Center clinics. And the concern I expressed, of course, was that neither the fairgrounds nor the clinics were present in the 5th district, which I represent, which has 400,000 people, more or less, and 36,000 of whom are Medi-Cal recipients, and so not an inconsequential number. Probably 60 to 70,000 of whom are seniors, the highest senior population, and in this instance, I'm going with 60 and above, pursuant to census data, and the fact that there did not appear to be a distribution mechanism here. I appreciate, Dr. Fenster-Scheib, the amendment to the plan that you shared with us earlier, but it still indicates that that broader distribution effort would be for what are identified, I believe, as at-risk populations. Do I have that right?
Yes, the plan, as you see it, our intent, as we discussed with you, is to ensure that everyone who is in a priority population has access to the vaccine. And so we revised it to ensure that our intent is reflected in the description. And so it's the clinics that we described, but not limited to those, because we will need other community clinics that serve the low-income, high-risk populations that will also need the vaccine when it comes time to roll it out to that group.
So my question for Dr. Smith or anyone you want to designate is how will that be done, and when will we know how that will be done? I am anxious that we not have delays in reaching that population anywhere in the county, but certainly in my district. And again, taken together, it's not an inconsequential number of people. It's 100,000 folks if you look at both the senior population and the lower income communities that I'm describing.
So as you know from the presentation, the ACIP so far has confirmed that healthcare personnel and residents of long-term care facilities are in the first wave. They have not yet come out with recommendations for any other priority group. And so the population that you're describing, we don't know as yet where they will come in the prioritization is done by the ACIP.
Let me try it this way, because I'm frankly struggling to get an answer that I think is responsive to my concern, and I apologize if it's because I'm inarticulate in framing the question. The plan as originally submitted and the plan as revised talks about serving a population in the county through the 9 clinics that are county clinics and the fairgrounds. Now, that's not for the initial dosage. That's for a broader distribution. My question is, how are folks who are in a similar population going to be served in areas like the 5th Supervisorial District that do not have either a clinic, county clinic, or a fairgrounds?
I can answer that. As Marty explained earlier, there are two committees. One is the Providers Committee, which is working on logistics. And we're in touch with the community clinics in the North County region, since we don't have county clinics in the North County region. And the two of them that are major candidates for the distribution are Planned Parenthood and Ravenswood, which used to be called Mayview. And also there's a discussion going on with Stanford. So we will cover all of those areas just like we cover the rest of the county with specific points of delivery. But as Sarah points out, the initial vaccine will not have sufficient numbers to be widespread. However, that will be the infrastructure that will be used once we get sufficient dosages to go out to the public, the general public, or the special needs groups, depending on what the ACIP tells us is the priority list.
Well, I guess my question, thank you, that's helpful in clarifying. The follow-up is, what's the timeline look like? And I understand that to some extent that this is a function of how much is released by the federal government and through the states distribution protocols. But what I'm concerned about is, will there be efforts in areas that are not proximate to the 9 clinics, the 9 county clinics and the fairgrounds, that on what is essentially the same basis? Or are we going to discover that there is some lag time and accessibility because of the initial exclusion of the folks I'm talking about?
No,
if I may, the pod locations will be throughout all geographic areas of the county, including in North County. And so we will, that's across the county, be they county clinics or community clinics, to ensure distribution to priority populations when those priority populations, regardless of when the wave comes, so that we can get it out equally once we're in that wave. I hope that makes sense.
Yeah, and just to augment on that, there will be no difference in timing among the various regions. There might be difference in volumes, in the sense that if the ACIP defines the priority groups in such a way that there are more people in one region in our county that qualify than there are in other regions, there might be volume differences, but there'll be no timing differences.
Thank you. That's helpful. And I want to be very clear. This is not about being parochial. This is about, which I think would be wholly inappropriate. This is about making sure that if we've got folks in one part of the county who are similarly at risk as folks in another part of the county, that no one is left out simply by virtue of the fact that they are living in an area that is already underserved in terms of the connection to a county clinic. Dr. Smith, is that a helpful clarification on my part?
Yes, that's very clear, and that's the intent, and
thank you.
We'll make it happen.
Thank you. This next question is not rhetorical. It's a serious question because it raises a concern for me going forward. So if there is a provider task force and if there is a stakeholder working group, how did we get to a December 1 plan sent to the state that overlooked 400,000 people in the North County and West Valley in the 5th Supervisorial District. And forgive me if that seems a slightly aggressive question, but I really am thinking now, how is it that everybody sat around a table and neglected to reference distribution to 400,000 people?
This is Dr. Cody. As I said before, the language that was in the original plan, well, one is we have community clinics and representatives from across the county on the community task force. So that's a way to check and to ensure that we're getting input really from everywhere. That's the intention there. The second thing I would say is that the North County wasn't excluded in the plan. We felt that the language was inclusive, but upon hearing concern that it didn't read that way to you, we augmented it to ensure that it was clear.
Dr. Cody, respectfully, I have to tell you that that is simply a patently inaccurate reading of the language in the proposed plan. And forgive me for being just that direct, ma'am, but when you say you are distributing at 10 locations, none of which are in the 5th Supervisorial District, that's not hard to comprehend, and it's not something inclined to misinterpretation. And particularly if we're talking about low-income communities who may lack transportation as well, the notion that they're going to get not once but twice to a remote location on public transportation 3 weeks apart strains credulity. So I will let it go at that, but my concern is precisely that if we have provider task forces and we have stakeholder work groups and we still ended up with that language, that makes me anxious that going forward, we could have similar oversights down the road. So I have been given your assurance today and Dr. Smith's assurance that that won't happen. And I am looking forward to making sure that the rollout is truly countywide, as you all have been kind enough to indicate that it will be. Now that raises a follow-up question, which is, to what extent, Dr. Smith, do we think that the county bears a responsibility for ensuring, as a matter of public health, that the vaccine gets to what I'm going to call the general population, meaning all 2 million people in the county? I know that the hope and expectation is that that responsibility will be undertaken by folks in the healthcare arena who are in the private nonprofit sector outside the governmental sphere. I'm thinking again of folks like Kaiser and Palo Alto Medical Foundation, Sutter Health. But we had that hope and expectation with testing, only to be disappointed, frankly. So as a matter of public health, don't we have to be concerned about making sure, particularly if herd immunity is the key, don't we have to be concerned about making sure that we have penetration throughout the broader public, not just the safety net population that is our primary concern, and understandably so?
Yes, whoops. Can you hear me?
Loud and clear. Thank you, Dr. Smith.
Okay. Yes, we certainly have that concern, and this plays to the question you framed as Plan B in the past, but is basically the question of whether or not the feds and the state fail us. You know, what can we do to assure the appropriate spread? How can we deal with the regulations and the prioritizations in such a way that no one is left out? And I agree, we do have a concern about that, want to make sure that that gets done effectively. And, you know, as we've talked about at a staff level, at this point, it looks like they're doing fairly well, although they keep changing the rules every 2 or 3 days. If they begin to fail, we have both commercial concerns, and so we will at that point approach the pharmaceutical companies, although it's been communicated to us that all of the distribution will go through the feds, but we also consider litigation and legal options and political options if we feel like we're not getting our fair share. And we're watching that very closely and preparing for it.
Dr. Smith and Mr. Press, presumably if the public health officer thought in her best professional judgment that a public health order was necessary to ensure that the vaccine was distributed and available through the private nonprofit healthcare sector in the county, such an order would be possible, yes?
Yes, such an order is possible. If, for example, we felt like a particular health system was hoarding or not complying with the federal state regulations or in some other way sabotaging the need in the community, there's certainly the possibility for a local public health order to straighten that out and litigation involved with that. Yes.
Yeah, I concur.
Thank you, Mr. Press. Thank you, Dr. Smith. And, Dr. Smith, I know that there were many members of the team on this when we were talking about testing who were hopeful that they could make progress on the testing issue through what I would call a series of extended conversations with our healthcare partners out in the community. But I think our experience with that effort indicates that, we lost precious months, frankly, in seeing a robust testing program stood up with help from others. And that ultimately that has necessitated the county to step up in ways that, as I said yesterday, are really heroic. I mean, it was a Herculean effort. But I don't think we can afford to lose a month or two or three in terms of the distribution of the vaccine should it come to that. And so, again, understanding that these public health orders are within the purview of the public health officer, I would just ask people to be mindful about the importance of moving sooner rather than later if there isn't real cooperation and compliance on the distribution of the vaccine. As a matter of public health, I just don't think we can wait. Go ahead, Dr. Smith.
I would agree with your concern. I think you asked me once sometime in June or maybe May how many tests per day we would need to have to feel confident that we were understanding better the transmission. And I said something like 15,000. We're now at 14,000, but it took a long time to get there because we couldn't get the cooperation we needed from some of the private healthcare companies. And it did eventually take a health order and a lot of talking and a lot of cajoling and a lot of threats. So they've also gotten fined in the process. So we'll be aggressive this time if we feel like they're disabling the process.
Thank you for that. On the privacy front, I don't know if Tuesday is too soon, but my understanding is that there was an announcement just earlier today about some technology and contact tracing using mobile apps. Is that an issue that staff is got any familiarity with, or is that another one where we should ask for an initial report on Tuesday?
Yeah, I can give you some information. We'll try to include more information later. This is a project that the governor's office and Apple and Google are working on in conjunction with a number of other IT entities. And what it boils down to is a app on your cell phone that you can opt into. Doesn't do any GPS location or involuntary identification, but you opt into it. And if you opt into it and it turns out that either you have the diagnosis of COVID or somebody that you've been in contact with who also voluntarily opts in gets a diagnosis of COVID, then you're notified and basically told to report to your physician or your public health department. There are, I think, reasonably some concerns about confidentiality, although the governor's office assures us that there will not be any tracing by GPS or any other involuntary way. We'll try to get you more information on Tuesday, but that might be a little soon because the details are still a little fuzzy. We'll try.
Thank you, Dr. Smith. If my initial understanding, and again, all this is breaking day to day, so I understand why we're all, hurrying as fast as we can to get caught up. But my initial understanding is that there's some representation that there's robust encryption that should give us some comfort about this. But might I ask that as you explore this, or let me suggest rather, that as you explore this, you not only include the usual HIPAA folks who you would include in terms of compliance, but also our chief privacy officer, since we have the benefit of having a small but mighty band in that department as well.
Surely.
Thank you. Last question, and then I'm going to thank my colleague, Ms. Ellenberg, for her patience and turn it over to her for a bit. I appreciated your anticipating my concern about a plan B, which is essentially what happens if others in the system are either unable or unwilling to step up in terms of vaccine distribution. Because Dr. Smith, as I understood the presentation, herd immunity requires us to get to 70%, and we can't get there if we aren't talking about the general population. Do I have that correct?
That's my understanding. I won't speak for Sarah, but everything I've read says 70 to 80% immunity, long-term sustained immunity is required.
Then could I ask you when we might reasonably ask for what I'll call a plan B document or work plan that says if we can't rely on others, here's what we're going to have to do and how we think we might do it, so that we have thought about that even in advance of the need arising. And even if the need doesn't arise, which God help us would be my first hope, of course.
I think I would have to ask you for a target time period at the second meeting in January so we can get a better understanding as this process begins next week, what lever points we have and how effective they might be, if that's okay.
Yeah, and I believe the second meeting in January is the 26th. Does that give us enough time to pivot if it turns out that our other potential partners are unable to deliver?
It won't give us enough time to do everything, but it'll certainly give us enough time to get back to the board with a plan.
Well, then let me make that request for the 26th, but with two caveats, if I may, Dr. Smith, understanding I'm only one member of the board. That's one where, just to be clear, I don't think a further delay is something I could or would support. So I'm laying that down as an absolutely essential date for having some opportunity to pivot if need be. And the other thing is that it really would need to be what I would call a plan that is actionable rather than a think piece or a review of the literature. Is that doable if we say the 26th of January?
I can speak for the administrative part. Probably Doug can speak for the legal part. Yes.
Okay. Mr. Press, what do you think?
End of January, that's probably feasible.
And Dr. Cody, any thoughts on that subject you want to share?
Nothing to share. Thank you.
Thank you. All right, thank you all very much. Much appreciated. Let me turn to Supervisor Ellenberg and thank her for her patience, and go to it, Supervisor Ellenberg.
Thank you very much. I have just three likely very brief questions for Dr. Cody. From information in the report, of the 17,500 doses that are expected in the first allocation, do we know the breakout, the proportion that's expected to go to SNFs versus healthcare workers, and how do we determine that? Does the FDA determine that? How does it work?
Sure. I'm going to turn it over to Marty in a minute for details, but basically that first batch comes to us. We know both from the ACIP and from the state's work, to make it a bit more granular, healthcare personnel in acute care facilities and healthcare personnel at skilled nursing facilities. Right. So we've taken vaccine off the top so that we, the county, will vaccinate the personnel that work at skilled nursing facilities, and then the rest goes to hospitals so they can get a start on their healthcare personnel. But of course, it won't go very far. And Marty, I don't have those details off the top of my head, but you may.
And let me just confirm that also. When you said they're going to the staff at SNFs, but not to the residents in the first distribution?
Yes, and that's correct. And that's remember the slide around that there's direct federal allocations, state allocations, county allocations. And so the federal government is making an allocation to commercial pharmacies who are charged with vaccinating the residents. And as Dr. Fensterscheid mentioned, we don't have any details about that plan. We are anxiously awaiting details about that plan. But for right now, with our first tranche, we do plan to vaccinate the healthcare personnel serving those residents.
Got it. Do you know what the timing is on getting more information about the CVS Walgreens plan?
I don't.
No, we're waiting to hear. The ACIP talked about it, and we understand that the SNFs and the long-term care facilities have already signed on with the federal government, but we're all waiting to hear what that will look like and how that will roll out.
Interesting. And how does that intersect with or relate to our role in vaccinating people?
So we're going to, yeah. So
please go ahead, Marty.
No. So because of the initial, again, the Pfizer vaccine, very small amounts, under 18,000 doses, the hospitals have to get some of their staff vaccinated this very first round. And we felt very, very strongly that the staff at the skilled nursing facilities needs to be vaccinated. The SNFs, not all the long-term yet, because there's not enough vaccine. But when you remember the slide that we showed that the SNFs had 5% of the cases, but 40% of the deaths, 44% of the deaths, and there's no visitors. So most of all of those are obviously coming in from staff. So in order to protect the residents, we need to vaccinate the staff. And because they're all small facilities, they can't handle the Pfizer vaccine. Now, they may be able to handle Moderna vaccine and subsequent vaccines, but we have taken 6,000 doses off the top, and we are negotiating and trying to figure out logistics so that we can provide vaccine either at our fairgrounds or through some model where we go to them, but we will get them vaccinated. Hopefully, they will not have vaccine hesitancy, and we're not quite sure how welcoming they will be, but we're hoping that they will agree to be vaccinated.
Interesting. And about how many vaccinators does the county have access to, or are we in the process of training more people to administer the vaccines once they do become more broadly available?
So that is part of the work of the vaccine branch, and they're recruiting vaccinators to work at the fairgrounds. And the various types of vaccinators might be contract nurses, public health staff, pharmacists, other county staff. I think they've been rather successful in building a team of vaccinators. I don't have that number, but I mean, I have it somewhere, but I just don't have it right at my fingertips.
That's fine. Let me just see if I can circle back and make sure I understand what we're doing. Will we, county staff, will administer the SNF worker vaccinations, the hospitals will administer them for their staff. And with that process, can we cover all of the people we need to cover with the 6,000 doses?
So you've got it exactly right with just one little amendment. So that's right. County staff will be the vaccinators for the SNF healthcare personnel. Hospitals will receive an allocation and they will vaccinate their own healthcare personnel.
Got it.
However, the first little trickle of vaccine that we're getting will not be enough for hospitals to vaccinate all their healthcare personnel.
And is it up to them to determine how they are prioritizing?
Yes. Yes.
Okay.
Within the hospital determines how to sequence their own healthcare personnel.
Okay, interesting. All right, thank you so
We
much.
estimate, Supervisor, that estimate that there's probably nearly 75,000 acute care hospital personnel. And so this first round, this first round is only going to give them probably 10, 12% of that. But subsequent allocations, we're going to be giving more and more vaccine as it comes every week. And so the hospitals will be allocated vaccine, and we hope if everything works out that perhaps by the end of the year or soon into the next year, we will have all of those acute care hospital employees vaccinated.
And we have confidence that that's a regular replenishment schedule. I thought I was hearing that 6,000 was the first and that there would be a significant pause before more already.
The 6,000 is the vaccines is a subset of the 17,500. So the first tranche from Pfizer is the 17,500. We're taking about a third of that off the top so that we can vaccinate SNF healthcare workers, and the remaining 2/3 go to hospitals.
Got it. Thank you. Thank you for clarifying that number. All right. I really appreciate both of you, Dr. Fensterscheib and Dr. Cody. Thanks for your time today.
Pleasure.
Thank you.
Thank you.
Thank you. Thank you, Supervisor Ellenberg. And just to follow up on that last point, Dr. Fensterscheib, I think when you and I had some conversation during yesterday's meeting, you indicated then, as you reiterated today, that we have been given assurances that there'll be essentially follow-up shipments on a timely basis that are the justification for going wide rather than holding on to the stock we have to ensure a second vaccination dose. Did I get that right?
Yes, our directive has been to everybody nationwide. I imagine, I at least know the state, that we are to use these first allocations as the first dose and are not to hold back the second dose. That will be coming. They don't want us holding on to these doses for a month while we can begin vaccinating people, because there is some protection after first dose, but of course you need to boost it for total effectiveness. So
thank you. You anticipated my follow-up, which is that, as I understood it yesterday, and I think you just confirmed that, in the off chance that there was no additional dosage available for, let's say, a couple of months, that the first dose on its own would have some beneficial effect. Yes.
Yes, we're told yes, but I don't know what the percentage is. But again, through the trials, you need the second dose to boost that immunity from wherever you get from the first all the way up to the 90-95% that you need.
And did I understand correctly? And forgive me because I did get a little lost in the weeds on this one. That even if the second dose was, instead of 3 weeks later, 6 weeks or 8 weeks later, that it would still serve a booster function, although not perhaps quite as effectively?
We don't know the answer, but ACIP, that's their job, and they will tell us what the range is for making sure that the second dose is given. For sure, there will be some leeway if it's a little late, but I don't know how late it can be.
All right. Well, thank you. As I say, I shared the interest and concern that Supervisor Ellenberg raised, and thought it was helpful and important to tease it out. Supervisor Ellenberg, other than to say thank you again to the team, anything else at this point? All right. Well, then we will say thank you again to the team, truly, and appreciate the effort to date, and know that it's going to be continuing struggle for all. So we thank you for that. Supervisor, let me check before I ask for a motion. Do we have speakers on this item? Looking to the clerk.
We do not.
Thank you. Then Supervisor Ellenberg, if you wanted to move approval, which is to simply to receive the report, I would give you a second and we would do a roll call. Motion by Supervisor Ellenberg, second by myself. And if we can ask the clerk to please call the roll, we will get it done.
Vice Chairperson Ellenberg.
Yes.
And Chairperson Simidian.
Yes.
Thank you.
Thank you. Motion approved. Thank you all. And thank you again to the staff. That would have taken us to item number 7, but again, for the record, item number 7 has been placed on the consent calendar. Thank you for that. Takes us to item number 8, which is to receive the report from the Office of the County Executive relating to the LGBTQ Health and Wellness Initiative. Dr. Smith, someone from your team?
Yes,
Afternoon.
Maribel is going to do this.
Thank you, Dr. Smith. Thank you to the committee. Good afternoon. This is Maribel Martinez, Manager for the Office of LGBTQ Affairs, part of the Division of Equity and Social Justice. I'm joined with Daniel Moretti from the Office of LGBTQ Affairs, and also Todd Landrino and Alicia Anderson from Behavioral Health Services. This is a 6-month report that summarizes the activities that have taken place since June 2020 and describes modified approaches to advancing the initiative's goal. The goals of the initiative are to 1, increase the level of LGBTQ competency in the delivery of health and wellness services, 2, increase the services that are responsive to the needs and prioritized by the LGBTQ community, and 3, improve overall health and wellness among LGBT populations compared against data collected in 2013. Although the goals of the initiatives remain the same, the efforts to reach these goals are constrained by the need to reduce in-person services to limit the spread of COVID-19, the deployment of county personnel as disaster service workers, and a serious structural budget deficit. With these constraints in mind, we are shifting toward an expanding access to services through virtual platforms, leveraging existing resources, and embedding new capabilities and services within safety net systems. I will hand it over to Alicia Anderson, who will share a little bit more about the Q Corner and some of the virtual trainings and activities that have taken place in the last 6 months.
Ms. Anderson, welcome. Thank you.
Hi, everyone. Nice to see you. Thank you for hearing about our update. So the Q Corner did launch, have a soft launch in the spring. Of course, our intention was to have a huge open house at our offices, but alas, here we are. We're very proud that we've been able to accomplish quite a bit in the past 9 months or so. We've worked diligently with the Office of LGBTQ Affairs, and collaboratively, we have essentially piloted about a dozen different online trainings to help expand the provider networks that are better prepared to support the community. That includes clinicians participating in an inaugural academy, that includes educators participating in a special training that we've launched throughout the Santa Clara County school districts. It includes families and other community providers participating in family acceptance project trainings. Many of these trainings are offered at least once a month. And the difference from what was offered previously to what is offered now is incredible. We've had participation from over about 75 different agencies throughout our entire system, which is remarkable. probably about 500 or so unique training participants. And that's just in the first 9 months. So we're extremely proud about that piece. I think it can't be underscored enough how important building and expanding capacity is throughout our system. And along with that, we're really focused on looking at infrastructure and how do we continue to enhance our systems to be set up in a way that better supports the community. So we are launching a Trans Care Coalition starting in January, which will be a partnership with, of course, the Office of LGBTQ Affairs, but with representatives from throughout our entire behavioral health service delivery system. We just opened our interest form for that on Monday, and already over 20 folks have expressed interest. So we're excited to see that a lot will come from that, in addition to all of the other infrastructure and capacity building that we're doing. And the other piece that we would like to highlight is I think we can all be candid here that it's hard to connect with folks right now. Folks are feeling very isolated, very much disconnected from community. We're doing as much as we possibly can to connect with folks virtually. We've launched support groups that are every week in collaboration with our Gender Health Center. We've also done a lot of creative and unique online web-based community building activities. We did a really kind of super fun trivia night with our Office of LGBTQ Affairs colleagues, but also trying to do what we can when safe in person. We had a really effective like non-contact or contact light resource kind of pickup event outside of the Q Corner. We also were partners with, but I don't want to shy away from, who really took the lead on this, the Project More group with our Office of LGBTQ Affairs colleagues hosted the LGBTQ Hello Wellness event, which was a really important event at the end of October to ensure that community members had access to a safe place to get COVID tests and other health services, take-home HIV tests, resource kits, flu shots, all of important comprehensive services. So we were lucky to be a part of that as well. So that's just kind of a sprinkling. I don't want to take up too much of your time. We're happy to answer questions, but ultimately, we are trying to be as creative as we can to connect with folks right now. The community definitely has been disproportionately affected by the situation that we're in. So we continue to be as much as possible hands on deck with collaborating with all of the existing community agencies to accomplish whatever we can to make sure folks feel supported. The very last thing I'll say is that the Q Corner did launch our social media about 2 months ago, and we are going strong. This is my plug for everyone to support us. I know Supervisor Ellenberg does. We've tried to repost as much about what you all are doing as well. And we've seen quite a lot of interaction from that. So we're really excited that we had the opportunity to create that account. And I think it's shown a lot of fruit so far. So thank you very much.
And I'll just share real quickly an update on the 5th and final stream of work under this initiative. So it's assessments and research, and it's really to further the understanding of needs and effective services. So we've been prioritizing research and assessments with segments of the LGBTQ community who are most underserved. So we have a transgender community assessment. The final report is anticipated this month. We're also having a mapping and gap analysis of transgender resources and services in the county that is anticipated to be completed the first quarter of 2021, and also an LGBTQ older adult survey that is anticipated to be distributed in the first quarter of 2021. So in closing, as Alicia was saying, we've made a lot of progress these last 6 months. We know there's a lot of work to be done in 2021 with COVID-19 impacts and recovery efforts, and we remain steadfast and committed to this mission critical initiative.
Thank you very much. I have a couple of questions in a moment, but let me just first make sure that we've gotten to everybody for the presentation. Have we covered that? We have. Okay, good. Thank you for that.
Thank you.
And let me go then to Ms. Ellenberg to begin the conversation, because I believe this item is before us at her request. And then, as I say, I have a few comments and questions as well. Thanks.
Thank you so much. I want to thank all of you for the report today. I have questions about a few different things that were said. But first, in looking at the report, I was just surprised that I didn't see any mention of the work that's being done by Billy DeFrank Center. They're in my district, very close to my home, so I tend to be very aware of what's going on there. And I know that the center has been kept open virtually as an active resource center for the community, with all sorts of diverse discussion groups specifically to counteract social isolation and maintain contacts. They've used the parking lot safely for Black Lives transgender support, the RBG vigil, a bunch of senior activities, and a Thanksgiving food giveaway. Just curious why they weren't included in the report.
Sure. Thank you for the question, Supervisor Ellenberg. The report recounts the activities that were done through this initiative that were county sponsored. Billy DeFrank, as a community organization, has actually done a remarkable job of continuing their programming and creating new activities. At this point, they are not funded by the county.
I see. So the report was focused on and limited to county funded activities.
That is correct. County funded and county partnered activities.
Got it. Okay, thank you so much. That's much clearer. The report indicates that Q Corner is currently located at a temporary site, and that your leadership team is continuing with long-term space planning efforts. Presented key, and it says that you presented key parameters and space needs to the county's administrative space committee. Could you share those key parameters and space needs with the board through an off-agenda report, please?
Yes, happy to.
Great, thank you. It also notes that the administration is considering how to expand services without having to invest in the development of multiple standalone programs or service centers. Can you tell me a little bit more about that, how it's being considered, and whether there are any preliminary proposals or recommendations? Sounds super interesting.
Sure, I'll begin, and then I'll also invite others to share how this is happening. A tremendous amount of our investment this initial year has been around trainings, and some of those trainings have been pilot projects in which have not existed in our county or actually in the United States. And so we are really developing the capacity within our systems to have them integrated into existing activities or existing systems within our county departments. So for example, we have some initiatives that include training and partnership with our probation department. And so some of those initiatives would be to look at how we can support already existing structures and already existing programs, but have them be more expansive and intentional in the way that they support LGBTQ youth. Another example that we're exploring is the wide investment that the county has already made in the youth mental health support through ALCOVE. And so are there opportunities through that mechanism where, again, we can make intentional supports for LGBTQ youth instead of having a separate LGBTQ youth focused entity or structure? And so we're really being thoughtful about how we can coordinate with existing organizations, existing systems, and building an infrastructure that leverages the wonderful resources and reach that we are already doing. I invite my colleagues from Behavioral Health Services to expand on that as well.
Yeah, I would just add that, and if it's not reflected in the report, I'll just underscore that this whole last 6 months has been entirely focused on collaboration. It's really the only way that we can all do this work. We have both formal and informal ways in which we collaborate with all of our partners who are all across the county. Of course, our friends at Avenidas and North County, our colleagues also in North County from Outlet and the even outside of our county walls and at the San Mateo Pride Center, but also and certainly with the DeFrank Center, like you had mentioned, all of that has been the focus, because really at the end of the day, we're all trying to accomplish the same thing. But everyone sort of has their specialty, areas of expertise, because we have some limitations in staffing capacity. That's the only way we can do it, is to do it all together. So I would say that has been extremely effective. I think we've all become a lot more communicative and collaborative over the course of the last 9 months. And we, I think, intend to continue those partnerships long term.
Great. It's really, I think, interesting and energizing to hear how, what has been so stressful and awful in so many ways for us to have lived through this and continue to manage in this pandemic. It's always exciting to hear about pivots that are positive and ways that we can work that we may not have thought of before. Just my last question is, since this does represent a change in focus, again, which I think is a really sensible one, are there community meetings scheduled or to be scheduled to get any broader input before plans are finalized?
So I could speak a bit to that. We convene, the Office of LGBTQ Affairs convenes a LGBTQ service provider and community-based organization network. And actually the first time that we convened them was about a year ago today, and was for input on the Health and Wellness Center. So we're going to be doing a follow-up, kind of meeting with them and presentation this upcoming Monday, sharing the updates around, some of the progress that's been made over the past 6 months, but also some of the challenges and constraints. So that will be, I think, one of multiple opportunities to hear input from that group that's continuing to grow, which is really inspiring. But we'll also look at, based off of the response and the feedback that we're hearing from that core group that's been involved, if there's, further input sessions, or if we want to expand out wider, kind of hearing about that as well.
Yeah, I'm always a fan of making the tent as big as possible. I really appreciate these periodic reports, and I would like to see this come back either to HHC or to the full board in May for another update, please. And thank you for all of your work.
Thank you so much.
That's it for me.
Thank you, Supervisor Ellenberg, and thank you to the team. Let me just ask a couple of follow-up questions. And Supervisor Ellenberg and I had some overlapping interests here, I think. Let me just ask, in terms of the Wellness Center effort, there was a look for physical space in both North County and South County, as I recall. Where does that stand, and what's the thinking about how that effort continues, if it does, which I hope it does?
I think at the moment, Supervisor Simidian, we are pausing on the physical location as we are able to assess best how county funds will be reallocated in this budget cycle. And what we've learned in the last 9 months since we went into shelter in place and then restricting in-person activities is that we are doubling our outreach efforts so that people from South County and North County are able to know and learn about resources through digital platforms and still have access to the same information and activities. And so we've seen an increase of participation from folks in those areas that otherwise would not have been participants in activities from organizations that are more San Jose central. And so we are really looking to how we can maximize those efforts and build on the foundation that we've done through these virtual activities, and as Alicia has mentioned, the wonderful outreach through social media that includes both Facebook, Instagram, YouTube, in terms of live virtual programming as ways to reach communities that have not always been engaged or have had the same access to activities. So until we have a better sense of our budget forecast for this work, we're going to continue to build on the virtual landscape of programming.
Thank you. I do. I want to come back to some of that, but I do want to say, I think I'm not familiar with the real estate market in South County. I know whenever we have conversations about physical locations in the North County, I hear from county staff about the cost of real estate in the North County, even modest space on a rental basis. But I'm thinking that there may be some opportunities in most senses, unfortunately, by virtue of the impact of the pandemic. So while I understand that you all are on pause, I guess through the county executive, I would like to suggest that we not miss an opportunity if there is a moment of opportunity here in the next 6 months, because at some point the pandemic, we hope and expect, will come to an end. And I would hate for us to have missed an opportunity that presented itself as one of the few silver linings of an otherwise very challenging time in everybody's life. So, Dr. Smith, I'm not asking for any other commitment except for you to indicate you heard me, if that's a fair request in the moment.
Yes, I heard you.
Got it. Thank you. And Ms. Martinez, thank you for anticipating where I was headed, which was whether or not there was in fact an opportunity here in the face of all this challenge, which is to reach out to folks sort of without regard to geography if we're looking at a virtual model. And I gather from your comments that you feel that is happening well beyond the boundaries of any one particular part of the county. Did I hear that right?
Yes, that is correct.
Thank you. Well, I think you know how enthusiastic I am about the good work you all have been partnering on with Avenidas. If my office or I can be of any help in promoting the services and reaching potential participants in other parts of the county, new parts of the county, areas where you are not yet as fully present as you might like to be, even virtually, you should feel free to ask us, okay?
Thank you. We will call on you for that.
Thank you. All right. I don't have any other comments or questions. Ms. Martinez, anything else from you or your team? I see a few other faces who haven't spoken, and I just want to make sure we're not overlooking anybody.
Thank you, Supervisor. That would conclude our, thank you.
All good?
All good.
All right. Thank you. Thank you.
Thank you.
All right. Then, Ms. Ellenberg, before I ask for a motion, let me just check with the staff to see if we have, with the clerk to see if we have any folks queued up to speak to this item.
We do have one speaker.
All right, let's hear from that speaker.
Thank you. Our next speaker is Sparky Harlan. I am unmuting you. Please accept the unmute. You'll have 2 minutes to speak. The timer will start when you begin speaking.
Hi, this is Sparky Harlan, CEO of Bill Wilson Center. I just happen to be listening in on this item, and I was on the Mental Health Services Act stakeholders group when we discussed this with Kaminar. I was on the committee, and we were actually pushing for a North County site. And one of the reasons is both Youth Space and Bill Wilson Center's drop-in center that does LGBT services are already one block apart downtown. And then all of a sudden Alcove came in. So now you have three basically youth centers. We thought Alcove was going to be primarily under age 18 and school-based, but then they went up to age 25. So I would say that we need to do some work to better coordinate when we start putting in a sense, all youth-related agencies, drop-in services, and an LGBT focus in downtown San Jose. And we still are working at our drop-in center and doing outreach to homeless youth. And we're closely with Billy DeFrank Center. They pride themselves in not taking county funding. They say that, you know, they'll leave the behavioral health services to us. But did want to make that point that we do work closely with the LGBT office and youth space and Supervisor Samiti. And I want to say we did put in a plug for a North County site when we talked about this probably 3 years ago. So thank you.
Thank you. Thank you all. And you know, at the risk of stating the obvious, while each of us as a district supervisor is particularly attentive to their own district, north, south, east, or west, central county, you know, the important thing is that folks who need and deserve the services get them. So as I say, that may be one of the few silver linings in the pandemic is the need/opportunity to communicate more broadly and serve more broadly by using the virtual tools. All right. The clerk can let me know, do we have any other speakers on this item?
We do not. Thank you.
Thank you. Then if I could get a motion to approve the recommended action, which is simply to receive the report. Motion by Supervisor Ellenberg, a second by me, Supervisor Samitian for the record. And we'll call the roll, please, Madam Clerk.
Vice Chairperson Ellenberg.
Yes.
And Chairperson Samitian.
Yes.
Thank you.
Thank you. Motion carries unanimously. That takes us to our final item, but it's sort of our omnibus item, and that is item number 9. Item number 9, of course, is the director's report, and it has a multitude of parts, A through H. So let me start with Mr. Santiago and ask you to walk us through this, please.
Well, for the first item, I provided a written report as timely as we could, and it is a little bit outdated in some of the information, but we wanted to make sure you had that information. In the interest of time, if there's any questions, I'll be happy to answer, but we'll go into the departments otherwise.
Thank you. I think the only question I would ask before turning to Ms. Ellenberg is a slight uptick in Medi-Cal enrollment. Do either you or Dr. Smith have any thoughts about whether that's noteworthy, important, significant, or just a blip?
Well, we anticipate this to be an increasing trend. Usually the situation is that people obviously lose their jobs, they apply for unemployment, and then once they apply for unemployment and they lose their benefits, they apply for Medi-Cal. So it's a little bit of a lag number. It takes a while for people to start getting Medi-Cal benefits. So, but given the impact of COVID in terms of the livelihoods of individuals, we expect this number to rise over time.
Got it. Dr. Smith, any thoughts on that one?
Well, I agree with Renee. COVID and a change in administration are likely to make Medi-Cal numbers increase, as well as we would expect our covered California numbers to increase, and hopefully see a decrease in our population that's uninsured so that they can get a better coverage, more comprehensive coverage. But we will still continue with our programs to make sure that they get coverage through the county.
All right. And Dr. Smith and or Mr. Santiago, would this be the appropriate time to ask for thoughts about a Medi-Cal waiver, or shall I just hold on until we hear from Mr. Margolin at the end of the director's report?
Well, we do have, as you know, in support of the state's request, a 1-year extension that given the incoming Biden administration, we certainly anticipate approval. It might be a gap that we're talking about here, but the state has indicated to us that they don't see that as a concern. They actually have been working at the administrative level to make sure that if indeed there's a gap or at the minimum, there would be some kind of a month-to-month approval until the incoming administration. we're hopeful, of course, that once we get a one-year extension, that we'll be able to get back to a multi-year waiver request post-COVID. And so at least we'll be able to have some level of stability there.
Got it. Thank you. Dr. Smith, anything to add on the Medi-Cal waiver issue?
No, I really don't. Renee's our expert in that.
All right. Good to know. Now we know who to send calls and questions to, Mr. Santiago. Ms. Ellenberg, anything else on the director's report before we move on to BCD, EFGH?
Yes, briefly. Thank you, Renee, and thank you all of the HHS departments for pressing both the compliance and the reporting of COVID testing levels for patient-facing staff as reflected in the reports this morning, for the reports for this meeting. Now you know when I read it. Thank you also for the thoughtful report and developing work on the Race and Health Disparities Initiative. I really appreciate the commitment to this work, despite the many, many other demands on our health system right now. We are all so poignantly aware that issues of race and equity are core challenges in the COVID pandemic as well. It's my hope that the community board can be ready to have their first meeting in January. I will look through my screen to Supervisor Ellenberg, Supervisor Simitian, and encourage you to appoint your folks to this board. Renee, what is your current thinking on the timing for the work plan development? And is it fair to expect that the next report to HHC might include a presentation on that work plan to be developed, of course, jointly with the community board?
Well, we're hoping, and this is, of course, we're working closely with Megan, clerk of the board, to make sure we're syncing up here and we get the input from the community stakeholders. We think it's going to take us at least a couple meetings, quite frankly, with the community board. One kind of an orientation, introduction, the next one coming into a review of the work plan. So we're looking possibly for February, quite frankly. Now, we do give you a little bit of the information, some of the pre-work that we're already doing in terms of looking at different frameworks, what other hospital systems across the nation are already doing, what we're doing already in our work groups and so we'll be able to compile that information, but again, we want to give an opportunity to community people.
Sure. I think that's great. I think that's a good place to start and a good first update. I'm excited to just see the formation of the group completed so they can all get to work. Thank you so much. That's all I have, Supervisor Simitian.
Thank you, Supervisor Ellenberg. And in case my office and my staff missed it, there was a subtle hint there that we need to get on it with respect to our appointments. So I'll just
subtle like a truck, please.
I'll underscore it, hopefully to good advantage and some good result. Thank you, Supervisor Ellenberg. And then that would take us to item 9B, which is a report from the public health officer. We have heard from public health earlier on the COVID issues, obviously. Anything else from public health today?
No, they don't have anything else.
Great. Thank you for that. And that takes us to 9C, which is the report from the CEO at Valley Medical Center, Mr. Lorenz.
Good evening, Chair Simitian, Supervisor Ellenberg. You do have a written report. I do have staff available as well as myself to answer any specific questions you do have. Obviously, Valley Medical Center, O'Connor Hospital, and St. Louis Hospital are at its highest census regarding COVID-19. Obviously, we also are impacted by our current patient load, which further complicates things. But I have to say to both of you and to everyone, I'm extremely proud of the staff at Valley Medical Center and the other two hospitals, as well as the outpatient system. People are being very flexible in understanding of the circumstances. I particularly want to express my gratitude to the labor organizations who have been with us side by side in moving through this COVID response.
Thank you. No questions from me. Let me turn to Supervisor Ellenberg.
Yeah, just a couple. And Paul, thank you as well to you and your team and the tremendous work that all of the staff at all three of our VMC locations are doing to maintain capacity and care for patients during this surge. What are you seeing in terms of percentages or numbers of staff out due to illness or quarantine currently? Is that having an impact on care levels?
It is having an impact, but to give some perspective, we probably have 50 to 60 employees that are out because of being COVID positive. That represents a very small percentage of our total workforce. But any number of staff being out presents a challenge to various departments and units. So at this point in time, we're able to manage, and we continue to monitor our staffing levels throughout the system. The testing that is going on, the asymptomatic testing that is going on, allows us to stay ahead of any potential further outbreak or exposure within the system. So that has helped greatly.
Good, thanks. Some speakers at public comment yesterday raised concerns about notifications to staff when they may have been exposed at work to a coworker or patient that is COVID positive. Can you just share what policies and practices are in place throughout BMC?
So anytime an individual is identified as being COVID positive, whether they're asymptomatic or symptomatic, we do go to extraordinary lengths to identify any potential exposures. And we do categorize those exposures as high risk or low risk. But we do contact those individual employees and notify them of the potential exposure. We also, depending on the department, notify other surrounding ancillary support departments relative to potential exposures within the workplace. So we have a very clear policy and practice for which we have implemented throughout the system.
So were you surprised to hear the comments yesterday? Did that sound like something that was a one-off or unusual? And are you able to follow up and see maybe what was missed in those cases?
We did follow up on that. And in fact, the staff in the departments were notified, and we did clarify that situation with the individuals involved.
All right, thank you. Thank you for getting right on that as well. That's all I have.
Thank you very much. That takes us to 9D, which is to receive the verbal report from the Director of Behavioral Health.
Good afternoon, Chairperson Simidian and Supervisor Ellenberg. And I apologize, I'm going to keep my video off. I'm in the middle of an internet outage, and so I'm using my cell phone to tether into the meeting. So I apologize for my video not being on.
No apologies necessary. Thank you.
We too submitted a written report with some updates related to our electronic health record implementation, NetSmart Avatar, which went live on September 1st. We've also provided some additional information. We've been quite busy with our Mental Health Services Act mid-year plan adjustment related to COVID-19 and our new innovation projects. And so you have that update there. And just to give an update, yesterday we received endorsement from our Behavioral Health Board for our plan, which will come back to you all at the board meeting on December 15th. We've been quite busy with our mobile crisis response team and implementation of our psychiatric emergency response project. And yesterday, we provided a full report to the board related to our school-based behavioral health services. So with that, we have several staff available on this meeting to answer any questions you might have. Thank you.
Supervisor Ellenberg?
No questions, just gratitude to Sherry. We've been in touch regularly regarding the mental health in schools program. I appreciate the progress and the thoughtfulness that's being put into this very, very big body of work.
Great. Thank you.
Thank you. And Mr. Rao, I'll add my thanks, particularly for the work on mobile crisis response team and the ability finally to get the PERT program up and running. Your thoughts about timeline for PERT? Forgive me now, I'm the acronym guy when I'm always concerned about that. Psychiatric emergency response teams, forgive me.
Yeah, so we've been able to hire one clinician who's been assigned to the sheriff's office, and we're actively recruiting for a clinician for the North County Palo Alto PD program. And so the Palo Alto PD has been actively part of our interview process. And we did interview several candidates in the last round, and unfortunately they went through the final selection process and then declined due to different reasons. And we are continuing to work actively with our employee services agency to continue to do specialized recruitment. We realize this program is very important, and so we are trying to do all we can to identify a pool of candidates that will help us to successfully implement the program.
Thank you again. Let me move us now to item 9E, which is the verbal report from the Valley Health Plan. Ms. Rosas, you need to unmute yourself, ma'am. Forgive me.
Can you hear me now?
Yes.
Yes, and I'm thinking that unmute should be the word of the year for 2020. So there you go.
I agree. Good afternoon, Supervisor Smitty and Supervisor Ellenberg. You have our written report. I just want to highlight a few sections. As you indicated earlier, we have seen an increase in the Medi-Cal rolls. We think this could be part of the elimination of the extra $600 that was given in unemployment earlier this year that may have made people ineligible for Medi-Cal, that now has gone away to a large extent, I think. And so that may be part of the reason why the increase has occurred. But we're definitely seeing an increase in Medi-Cal, and I think that will continue, unfortunately, from an economic national perspective. But we also think that having a friendly administration to the Affordable Care Act will see an increase in Covered California. We're already seeing an increase in Covered California for the last few months since we've had an extended enrollment period, and we're now in the official open enrollment period. Covered California has been doing a lot of work around social media, and we've engaged with them, and we're also doing a lot of outreach around Covered California. We had our own event with your office a few weeks ago. It was very successful, lots of attendees and good questions. So we expect that will continue to grow. We've also, other successes we've had in the last month or so is we've done a full revision and update of our provider manual for the commercial and Covered California lines of business. And we are working on a full revision for the Medi-Cal line of business as well. And those are my updates in addition to the report that you have. Thank you very much.
Thank you.
Do you have any questions?
You were kind enough to mention the pair of open enrollment events that my office co-sponsored with VHP. So let me say thank you for that. And just a brief response, if you could, please. I fear I may sound very naive with this question, but I was struck by how much work you have to do to reach a relatively small number of people. And I could see you smiling. Is this the norm? I mean, a lot of work to get to a relatively modest number of folks in a county of 2 million people, and sort of bring them through the process to actually then engaging them and delivering a product that works for them. What's your take on that? Is that what you're doing every darn day and I'm just missing it?
We do work very hard. We have a sales and broker team that works incredibly hard to be able to get the word out about Covered California. So we do have a pretty large network of brokers that we work with that are really critical, and ensuring that we have brokers in areas where people can find them accessible and in a language that they need. So whether it's Vietnamese or Spanish, that's also really important. And so we work very hard on the broker side. The thing about health insurance is that it's really complicated. We have a really complicated healthcare system and a really, really complicated way of paying for it. And explaining it to people and engaging them is hard. One of the things that we do that's unique at Valley Health Plan is we actually have a new member orientation where we'll schedule, we used to do this in person, obviously we've moved it to remote, where we'll actually schedule an evening, I think 2 evenings a month, where we'll walk people through what is it like to be a member at Valley Health Plan. What are the things you need to know? What services are covered? What do you need a prior authorization for? And we'll walk, we don't get a lot of attendance for that, but we put it out there. We continue to get the word out. But it is an uphill climb to get people to engage in health insurance and thinking about that, especially with so much going on. It's a really difficult time to communicate, across the board, and not being able to do the kind of in-person engagement that was such a big part of our open enrollment period. We really were out there in the community we would do events, everywhere, and we just can't do those things. So we've really moved everything to digital.
All right. Well, thank you. Thank you again. Supervisor Ellenberg, any comments or questions for Valley Health?
A quick comment, Laura, I was really pleased to see the addition of a senior VHP position to coordinate mental health services for members and build partnerships with behavioral health and others that was approved on yesterday's consent agenda.
Thank you.
I'd just like to request that updates relative to expanded behavioral health services be included in future VHP monthly reports.
Absolutely. We're going to be revising and revamping our reports. So you'll see changes over the next couple of months.
That's exciting.
Thank you.
I was glad to learn about that.
Thank you very much. That takes us to 9F, which is the EMS, Emergency Medical Services. And I think we have someone still with us to help us with that item. Yes?
You do. Good afternoon, Supervisor Sumedian and Supervisor Ellenberg. This is Jackie Lowther with EMS. I too apologize for no picture, but I'm kind of recovering from a recent surgery. I will start and then turn it over to Dr. Miller. You have our report before you, and just a couple of additions. This one is basically for October. However, as we all know, things have changed a little bit since October. And beginning in November, our transport volume decreased a little bit, as well as our transports per day. In October, they were 222 transports per day. November had slid down to about 212 per day. Well, in the first 8 days of December, we were at 232 transports per day, and we're averaging about 344 calls per day or requests for service, which is about where we normally would be in, say prior to the pandemic. Performance has been managing. What we are starting to see is what we would normally see at the end of December and early January and February, where the hospitals are really beginning to have challenges in offloading patients. It is far worse because of the challenges they have with, the COVID, the respiratory, and trying to clean up between patients. So we're beginning to see the hold times at the hospitals increasing at a far earlier rate this year than normal. We're working with the hospitals, a few of them, on their strategies for surge and what we can do to assist them. So it will be a very long winter, I am sure. But the ambulances, first responders, as you see, are still maintaining all of their response compliance, as well as rural metro. They're holding firm and really working to keep, to get to all of the, people of Santa Clara County on time. But we have strategies in place if it continues to get worse. Is there any questions that I can answer for you? And Dr. Miller is here to go over our stroke data for you.
No
Thank
question.
you.
Thanks, Jackie.
All right, no questions from Ms. Ellenberg. No questions from me. Just a quick thank you for the off-agenda report, just so you know that those are duly noted and appreciated. So thank you for that.
You are welcome.
All right, that takes us then to the next portion of our item 9 list, and that is custody health. We have a verbal report there as well.
I got attached. Dr. Day is having difficulty from the main jail to connect. The internet is off for whatever reason, but I know that she submitted a written report. I don't know if Dr. Day has been able to connect via phone. And if there's any questions, I'll go ahead and try to answer them or make sure that we respond to it in an agenda memo.
Let me check with Supervisor Ellenberg. or we could simply send additional questions if we have them and ask for an off agenda. Supervisor, what's your pleasure?
I'm happy to do that. I have 2 questions and we can send them along to Dr. Day.
All right.
Sorry to interrupt, Chairperson. Let me try to promote Dr. Eureka from the attendees and see if that works.
Well, I wish you could give us all a promotion. That would be great, but go ahead and give it a try. So.
One moment.
Yeah,
Dr. Day?
Seems to
Yes, can
win
you
every
see me?
part.
Awesome, thank you.
Perfect. Okay, I'm not sure what's going on with the technology, but good afternoon, Supervisor Semidian and Supervisor Ellenberg. I hope you're doing well. Okay, and I'm Eureka Dane. I'm the Director of Custody Health Services, and this is a report that I'm summarizing for the quarter. And the quarter is from August 2020 to November of the 2020. And as you are aware, Custody Health Services continues to work very closely with not only our custody colleagues in the Bureau and the Sheriff's Department, but with public health. We are committed again to following all of the guidelines from CDC and from the County Department of Public Health. We are providing weekly COVID-19 testing to all of our staff, and so that is going very well. And we also are doing the surveillance asymptomatic testing. For the quarter, Custody Health Services completed 5,571 COVID-19 tests between Main Jail and Elmwood. And then we completed another 280 tests for our youth at Juvenile Hall. Our positivity rate continues to be very impressive. I'm very proud of that. We're doing an aggressive job with our COVID-19. Our positivity rate for the quarter was 1.3. And for Santa Clara County, it's running about 2.5, and for the state of California, 3.35. And so we are running lower than the state and the county as far as positivity rate in our custody health services. We also continue to realign in real time any of our policies and any of our standardizations and our procedures and guidelines for COVID-19. As you know, these change with CDC as well as with the county public health department. We also are very dynamic and fluid in making sure that information gets out to our staff in real time. We're having bi-monthly town hall meetings with our staff so that we keep information in front of them and so they could also answer any questions. We've also moved to using only surgical masks and using shields in all encounter areas where we're treating our patients. That includes not only the booking area, but the infirmary, any of our outpatient ambulatory areas, as well as 8A. And so we're being pretty aggressive with that. And we also have started with our dental services that we require all inmates seeking any kind of procedure with dental, that they are also submitting a white card and being tested prior to their procedure with dentist. And so that's the report I have so far. If you have any questions.
Thank you. I know Supervisor Ellenberg had a couple, so let me turn to her.
Sure.
Thanks so much, Dr. Day. Can you provide a current update on the status of the COVID clusters in youth and adult custody health facilities and among correctional staff?
Yes, right now we have 11 positive patients at the juvenile center. We had
are those patients, sorry, are those kids or staff?
These are youth.
Okay.
And we have 11 youth right now. We had 12 and one has been basically resolved. And as far as our adults, we have 10. And so 2,181 patients, we have 10 positive adult patients. And out of 94 youth, we have 11 positive.
And were they tested, did they test positive when they came in or did they contract COVID while they were in our custody?
For the youth, they contracted while they were in our custody. For all of the adults, we caught all of those at booking. And so all of those patients coming in, all of those positive tests for the adults we caught at booking.
Okay, thanks. And do you have similar data for staff at adult and youth facilities?
I don't have for staff in front of me. I can tell you what we've tested for staff, but I don't have that in front of me right now. I do know that we have I don't have those numbers in front of me. I'm sorry.
Okay, I'm happy for you to send them to us off agenda.
Right.
That's not a problem. What's the status of bringing on additional custody health staff to provide expanded COVID testing of asymptomatic youth and adults in custody?
Sure. And as you know, we've been canvassing for extra help for some time now. We've actually screened over 100 viable candidates for extra help. We had 21 in the pipeline. However, as you know, everyone is competing for the same resources for testing. And so we currently have 7.6 staff right now that's extra help. We started out with about 21 and those fell off because these are extra help staff. And so as they're getting full-time employment opportunities, that's what they're taking. But so far with our 7.4, we have been able to provide the bi-monthly testing with no issue. We started the bi-monthly on 11/3 for our custody health staff, then on 11/30 for our custody colleagues.
And are you working to ramp that number back up with extra help?
We are. We have constant surveillance and we're constantly surveilling. I'm also looking at a more sustainable process because as you know, this is going to be ongoing. And so extra help is just not sustainable because we bring them on, we onboard them, we train them, we orientate them, and then when they get up for a full-time position, they end up leaving us.
Yeah, don't blame them, but it doesn't work for us. Thank you so much. I appreciate the report, Dr. Day.
Sure, thank you.
Thank you.
Thank you, sir.
And I have no comments or questions today, so I'll just add my thanks as I say, and we will go to the final item on item number 9, which is 9E, and that is, 9H, and that is to receive the verbal report relating to the federal health policy and budget landscape. And I believe Mr. Margolin is going to join us for that. Yes?
I'm here.
Thank you, sir. What should we know?
Well, there's a lot going on. Good afternoon, supervisors. Lame duck sessions of Congress are always somewhat odd affairs, but the current lame duck is unusually odd in that you have this very challenging transition from one administration to another, overlaid with the COVID relief challenge and the effort to get that COVID relief package passed during this incredible crisis that we're confronting. So it makes it especially hard to assess and to deal with developments during the lame duck, but I'll do my best to summarize where things are. You will recall that in October, COVID relief negotiations between Speaker Pelosi and Mnuchin were very intense, went on for several weeks, and ultimately failed prior to Election Day because the politics of the election just doomed that effort. Right after Election Day, it looked as if COVID relief would be not be addressed in the short term because the president refused to concede. He had no interest in the substantive work of the lame duck. And the conventional wisdom for a while, at least, was that this would be a President Biden issue. Then in November, a bipartisan group of lawmakers driven by a group in the Senate, but joined by a package of a group of House members from the Problem Solvers Caucus, came together and unveiled a $900 billion package. This bipartisan package was double what Senate Leader McConnell was willing to offer, which in October had been only $500 billion, but it was only half of what Pelosi and Mnuchin had been talking about. So at the beginning, people thought, well, this isn't going to be enough to attract the attention of the Senate and House Democrats. But within days, Pelosi and Schumer both endorsed the general concept of a smaller deal at $900 billion. And then President-elect Biden weighed in and said, this wasn't enough money, but it was a good start. So let's take it, let's pass it. So all parties then began to focus on a deal in the $900 billion range. The key here is that it would be less than $1 trillion, and that was the test or threshold for Senate Republicans. They didn't want to have a $1 trillion package. Anything less than that, they were open to. Just this morning, there was a 5-page document released which outlined key elements of the bipartisan Senate House group, what they were actually talking about. And their package includes $160 billion in support for state and local governments. It's an agreement in principle. There are no details, but it's there, 160 billion. They also have supplemental unemployment insurance payments set at $300 per week. It's only half of what we previously had when it was $600 per week, but it's in there. They also, in their package, would replenish the Paycheck Protection Program with $300 billion of new funds to help small businesses survive during this period. They put another $35 billion into the Provider Relief Fund, which supports healthcare systems and which Santa Clara County Health and Hospital has been able to draw on in the past. And they have $13 billion for vaccine distribution and testing and contact tracing. Most of that goes out in the form of grants to states, with the Secretary of Health and Human Services having substantial discretion over how that's to be structured. So many other provisions, but those are some of the key ones that we all are following and care about. And it's good news that it's out there, and it's $900 billion. That's what the bipartisan moderates want. And we have this agreement, this consensus about $900 billion as the target number. In the last day, same time this document's been unveiled, the White House has weighed in, and Senator McConnell's weighed in with proposals that further complicate matters. First, Mnuchin, on behalf of the White House yesterday, said they're okay with state and local money, which is a breakthrough, which is good. They're willing to support in this under $1 trillion package state and local money, but they want the unemployment insurance supplemental payments to be dropped. And instead, they want a direct cash payment to individuals, $600 per person. Pelosi and Schumer have responded by saying that's a non-starter. They're not going to give up on even though they appreciate state and local money being there, they're not giving up on the unemployment insurance money. At the same time, roughly in the same time period, Senate Leader McConnell came out with this proposal. He said, listen, this is complicated, state and local money, trying to figure out all the other issues here. Let's take two of the most contentious issues and drop them from the package. He proposed eliminating state and local dollars totally, the $160 billion gone, the money that Schumer and Pelosi care a great deal about. But he said, as a concession, I'll also take out of the package my main priority, Senator McConnell's main priority, and that is liability protection for businesses. We'll drop that, and we'll have a negotiation over state and local and liability next year. That's the proposal that McConnell put out there. Pelosi and Schumer both said no to that. That's a non-starter. They must have state and local money. So all sides, on the one hand, are closer than they've ever been before, because finally we have this consensus about $900 billion. Instead of talking about 3 trillion, 2 trillion, 1 trillion, 500 billion, we've got this consensus on a little over 900 billion, just under $1 trillion. But on these specific issues, state and local funding, liability protection, unemployment insurance, the positions have actually hardened in the last day or so. So it's a tough negotiation ahead of us. This is the timing. Congress is in the midst of passing a continuing resolution, a CR, to extend funding for the government from December 11th to December 18th. The House actually passed their version earlier today. The COVID package, whatever form it takes, is going to move at the same time a budget deal is done. So it's now, the new deadline for that is December 18th. We might end up in this budget deal with another short-term CR that would take us into February or March. That's one option. Or it might be an omnibus appropriations package that funds the whole government for the entire year. Not clear, but we do know that COVID, if it's to be done, will be tied to this December 18th deadline. One other item of concern to the county, in the midst of all this, we've been given a number of assurances that in whatever extension is done, the deferral of the dish cuts that the county's been following that would be very harmful to the county's Medicaid funding will be included in whatever package is passed. And there's even the possibility if it's an omnibus budget deal that we could have a 2-year deferral, not committed to fully yet, but there's a chance of a 2-year deferral. So we also know, one other point to make about all this, we also know that no matter what happens with this $900 billion deal, it's not enough money. President-elect Biden's made that clear. So there'll be another negotiation in February over either additional money, or if this deal falls apart, they'll start over again with a much bigger number. The Georgia special elections on January 5th are obviously going to have an impact on how this next negotiation goes. If Senator McConnell is still in charge, that's one scenario. If the Democrats pick up both seats, you have Schumer in a different scenario entirely. But the other dynamic that's been made clear here is that no matter who's in charge of the Senate in terms of the leader position, whether it's Schumer or McConnell, because of the way this moderate package came together and because of the traction it gained, we're going to have Senator Collins, Senator Manchin, Senator Coons, Senator Murkowski, Senator Romney, and others, the sort of so-called moderate caucus driving future deals on controversial issues. The last issue I want to just touch on briefly is the issue involving the nomination of Attorney General Becerra as the next Health and Human Services Secretary. This is good news for California in that if Becerra is confirmed, we know he'll be very responsive to the healthcare financing needs that California will have in the coming months. I know Renee talked about the waiver extension, and we're hoping for this 1-year extension, but we know whether we get the full 1-year extension or whatever or not, there's going to be an intense waiver negotiation next year with the Biden administration, and it would be helpful to have Becerra in that role. While there's a very good chance that Becerra will be confirmed, it's also useful to note that several Republicans have already come out against him based upon his support for the ACA and his opposition as Attorney General to multiple Trump administration initiatives. So it's not entirely clear that he will win confirmation. His fate may be tied to the Georgia special elections, although I think even with a loss for Democrats in Georgia, given his background in the House, his experience in the House, and the relationships he has there, it's likely he'll be confirmed, but clearly not assured, given this early Republican opposition. Happy to respond to any questions you might have, supervisors. That completes my update on the federal budget negotiations.
Thank you. And Ms. Ellenberg, any comments or questions? I have just one brief clarifying question, or at least I think it's a brief clarifying question. Go right ahead, ma'am.
I don't. Always appreciate the updates, Bert. Thank you.
Thank you.
Thanks. Mr. Margolin, I just want to understand a little more clearly. One of the areas of contention, if I understood it correctly, was one side in the debate about the $900 billion effort wanted grants to go out as direct cash grants, and one side wanted them to go out through the unemployment insurance process. Is that?
So that's close, but here's, maybe I went a little too quickly on that point. So there is strong support for unemployment insurance supplemental payments among members of the House and Senate, Democratic leadership, Democrat rank and file. They want unemployment insurance, which was at $600. Now there's a proposal for $300 to continue. What Mnuchin did is he said basically, we don't want that. We want to keep it under $1 trillion. We want to take the money that would otherwise would have gone for unemployment insurance. We want to zero that out and transfer that funding to a direct grant, just a direct payment to people who are, every person. So it's just like the earlier stimulus funding that was distributed months ago. You could be employed, you could be unemployed, everyone gets a check. And so it's not so much that they want to take the unemployment insurance. I mean, it is true that they're taking the money that would have gone for that purpose, but it's more a question of one group, the Democrats, are prioritizing unemployment insurance, and there are even Republicans in the Congress who think that's where the money should go because those people don't have jobs. And then there's this Mnuchin proposal, which could really complicate the negotiations, in which he says, we want a pure stimulus check. Is that any clearer?
It is, and I just, but I just to follow up briefly, I just want to be sure. And the argument for that is, and I heard you describe it as stimulus, but presumably the same amount of money would serve as the same stimulus function if it went out as unemployment insurance. So I'm just trying to understand what either the policy rationale or the political motivation is for saying, no, we'd rather just send checks to folks sort of across the board rather than direct them to people who have been identified as requiring unemployment compensation.
Right. So I'm not sure there's been a fully developed policy rationale because if you look at it in purely policy terms, people who are unemployed need this help above people who have jobs, in some cases, good paying jobs. But we know that the Trump administration was very happy with that stimulus check from months ago. And the president and his team thought that was a great way to show the American people that he was engaged and being supportive. So this may be a combination of ideology, it may be a combination of wanting to return to something the president liked from several months ago. I have not seen a clear policy rationale that would make the case that a check to everyone is better than targeted unemployment insurance. I haven't seen that argument.
Okay, thank you. That covers my questions. Ms. Ellenberg, you're good to go. Then before, we'll say thank you, Mr. Margolin. Well done as always. And let me just ask the clerk, do we have any speakers still with us for item 9 in any or all of its parts?
We do, sir. We have one speaker.
Let's go ahead and hear from that speaker, please.
Thank you. Our next speaker is Scott Largent. I am unmuting you. Please accept the unmute. You'll have 2 minutes to speak. The timer will start when you begin speaking. Scott, can you unmute one more time, please?
Oh, thank you, everybody.
Thank you.
For some reason, technical difficulties all the way around the board today. Okay, what I'm kind of wondering is why it's so hard to find talent in the behavioral health department with our county. It looks like we got one person coming on board right now. We're making it so difficult to hire people in Santa Clara County when we have talent right in front of you in a way. We have some retired social workers that are volunteering their time downtown. You know, these people really care, and you guys need to bring them to the table. They're volunteering their time. They know the community. You know, they used to work for you. There's a lot of them downtown right now, and they're trying to do the work that the county's not really doing. Behavioral health operating remotely doesn't cut it. Most of the people living on the streets that are mentally ill, drug addicts, their phones are garbage. The Obama phone can only load about 5 apps on there and function properly. They can't even charge their phones. So how are they going to be able to participate in, for instance, Judge Manley's courtroom? He now has an interactive thing where you can go online and check in. I've been listening in on those conversations, and I'm telling you, 90% of the people are not even there. They cannot pull it off. And I'm somebody that's been sober almost 5 years. I'm dealing with homelessness right now, and it's hell to use the bathroom, to charge my phone, and to just do basic things that have just been ripped out from underneath me. There's no rec centers. There's no law libraries right now. There's no water at the park. There's no functioning bathrooms. And I know I say this over and over again, but these poor people, I couldn't imagine if I was still on meth. I'd be going absolutely insane. But hey, guys, that's what's going on outside your front door right now. Get these people some care and get people in there that are willing to take the risk to go out there and talk with people. A lot of these people just need somebody to be there for them, not on a cell phone or a Zoom meeting. Thank you.
Okay, that concludes our speakers.
Thank you. And Madam Clerk, I believe that is the last of our speakers and the last of our items, other than the items that we have previously addressed on consent calendar. Is that your understanding as well?
That is correct.
Thank you. Then without objection and hearing none, I will say thank you very much to all who participated today, and we stand adjourned. Thank you.
Thank you, everyone.
Thank you.
Good evening.
You too. The meeting has officially adjourned. Thank you so much.